The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to the Success in Practice podcast. Today, I'm joined by Jonathon Booth. Jonathon is an osteopath in his third year of practice, graduating from RMIT in 2001. Originally from the UK, he moved to Geelong at an age of 11, where he finished high school. After a first attempt at university in Townsville, he found a passion for snowboarding and followed winter between Mount Buller in Victoria and Jackson Hole, Wyoming in the USA for about 11 years. A significant back and knee injury in 2010 led to Jonathon's first exposure to osteopathy. This was also a turning point in his career as an opportunity arose for Jonathon to gain employment in Queensland as a machine operator in an underground coal mine. After 6 years in the mines, he decided it was time to find a less hazardous career and decided osteopathy would be a good fit. Not so sure it's less hazardous, mate, but good try. At 39, Jonathon commenced study at RMIT, graduating at 44. He has since worked in a private clinic in Mernda and is currently practicing at Complete Health Clinic. Is that right, Jonathon?
Complete Health Osteopathy.
Complete Health Osteopathy in Gladstone Park in Melbourne, in Melbourne's northern suburbs. And so, mate, definitely easier to work as an osteopath than it is in the mines. So it's a different, I'm sure it's a different set of people that you're working with too.
Yeah, very differently. It's lots of great people up in the mines, but it's a different kettle of fish.
You need to go back up there as an osteopath, mate. There'll be a lot of bad backs up in the mines.
Well, especially at the moment, the mine I used to work at is actually the one that's on fire at the moment. So there'll be a lot of people sitting around with spare time on their hands looking for a bit of a tune-up. So,
Jonathon, mate, the reason I think, well, not the reason, but I think the best thing that we can talk about, you're 3 years into practice, so I want to really understand some of the challenges that you're going through and some of the things that you really enjoy about practice and some of the things that you're finding tough and challenging. And so I've been wanting to kind of discuss that with people. You're also a graduate of RMIT, so you have very recent experience of the program there. And I wanted to get firsthand knowledge of what somebody who's been recently graduated went through to get an understanding of what the education of osteopaths is like in today's climate. And so I think that's where we'll get the best value for the listeners. I also want to discuss a little bit about what you're doing in terms of treatment as well. I think it's good to discuss that and to give people insights as to
absolutely,
where you're going as an early career osteopath. And so tell us about that, mate. Let's get started. First question: what are you doing these days? I mean, tell us about your work week. Tell us about how many patients you're seeing, where are you working, what kind of influences you have, and how you're treating.
So I've about a year ago, I moved to the current clinic I'm at, where I'm renting a room there through my partner's business, and slowly building a book there. So it's been busier through the first half of the year. It started a little bit of a lull at the moment, but I'm seeing sort of anywhere from sort of 15 to 20 patients a week generally, just over 2 days. So I'm just building it there and then expanding as I go along. So.
Okay, good. And you're working at a clinic also alongside some other osteopaths, is that correct?
Yeah, that's correct. So the principal there is Syed Hussain, who graduated about a decade ago, I think. Very, very driven man, very strong mentor, which is something I was looking for as well. Great educator. I definitely knew going into this I needed some support. I wanted a bit of a fast track for my career. Being a bit older, I didn't have the sort of luxury of sort of easing into it. I wanted to push myself pretty hard, and learn as much as I could, as quick as I could,
Mate,
and
one of the
surround
things
yourself in
that,
strong people.
yeah, you're
Sorry.
right, you're right. One of the things that attracted me to having a chat to you was that you are a mature age graduate. You know, I think you started, how old were you when you actually started osteopathy?
So yeah, first year RMIT, I was 39.
You were 39,
Yeah,
and you
yeah,
graduated at 44.
that's correct. Yeah.
So that's a different mindset to somebody
Mm.
who's, fresh out of high school, or even, maybe he's done a 2-year degree in health science, and decided they want to do osteopathy. So you'd be a good person to talk to, because I think you'd have a pretty well-rounded understanding of your education, and what that's provided for you. Before I get to that, though, let me ask you about some of the challenges at the moment that you're finding as an early career osteopath. Like I said, you've got more of a mature mindset, but you're still young in your career. What are some of the things that you found difficult?
Um, I mean, I think it does stem back to the education, and I know we're going to talk about that in a bit. But certainly, so my first role out was at a clinic in Mernda, um, and there were days driving up the road. It was 15-minute drive up the road. There were days up the road where I really didn't know why I was going to work. I didn't feel I was going to be delivering quality treatment. Um, I didn't know how to speak to my patients if they were returners who weren't getting the results that they were paying for and that I was expecting to be able to give them. I found it quite confronting, especially having walked away from one career to take up another one. Um, Put a lot of effort in at uni to get good grades, and I wanted to extract as much out of that as possible. So I was job ready, and really didn't feel job ready at all. Um, the challenges now, that's settling down a fair bit. I'm getting a lot more
Did,
confidence just getting my hands on people.
did that
Um,
create? Sorry, did that create a bit of anxiety for you back in the day when you were first starting out?
Massive, yeah,
Yeah,
massive. It was, I chucked in a six-figure job to go back to be a broke uni student for 5 years at 40, and I was now looking at possibly stepping away from that before I'd even had a chance to make my first HEX debt payment. So it's not sort of in my nature to get beaten by those things though. So I did stick with it, and I'm really grateful that I did. The other thing that really helped was I had a mentor in Cameron Keeley, who actually I went for a job with him. Didn't get the job, but he very kindly invited me to his in-house training every week,
yeah.
and he gave me some of those basic skills, those raw skills, as well as some more advanced techniques and different ways of thinking that meant that when it came to going to work, I had something to say, I had something to do, I had some value to deliver to my patients, and had a mindset of treating every patient as an opportunity to learn, just to give service, and sort of earn my reason for being there. So,
Yeah,
but
Cameron's
yeah,
a good
it
guy.
was tough.
Definitely. We'll talk to Cameron, try to get him on the podcast. He's a good guy to
Yeah, it's
talk
great,
to.
mate.
And it's a good thing that was that something that you searched for, or did Cameron kind of just pop up on your radar by
No,
accident?
it was definitely it's sort of a lot of um, a lot of job ads spruik support and CPD. I can't remember the exact wording um, of his job ad, but it made it very clear he was very serious about committing real resources to making sure that whoever was on board, even as a new grad as well as his existing staff, were going to be given every opportunity to improve in a setting that's conducive to that. And so that really attracted me to the job. And then when I was there, when I didn't get the job, I said to him, "Is it okay if we can have a bit of a debrief? I want to know why. It's all well and good that I didn't get the job. That's fine. If I'm not the best fit for the clinic and someone else is, I'm not going to take that personally. But I can't grow if I don't know." And so I sat down and had a chat with him, and expressed that I'd be interested to sort of maintain contact with him in his clinic. And he very kindly reached back out to me and gave me that opportunity to have a chat to him, and also invited me along week on week to join his staff and develop some skills. So very, very grateful.
Mate, that's good. You put yourself in the best possible. You put your best foot forward there, right? So,
Mm.
yeah, like it's like a coach of a footy team, and they've got their 17 players already picked, and along comes this bloke, and he just the effort's there, the talent's there. They might be missing a couple of things, but as a coach, you'll always have a look at them. You'll always give them a chance because they're expressing a desire to want to play and want to learn and want to develop. And I guess when you express that desire to Cameron, mate, he would have just. I think any person that's sane would not let that go. You'll definitely want to pass that on. So that's great kind of information for graduates coming out now. Is just put your best foot forward. Always put your best foot forward and don't take things personally. And if things don't go your way, see how you can use them to learn, right? It's either like you win or you learn. You should never lose. So that's a good example of that. So now you're working, and tell us about your treatment now. Like, what are some of the things? How would a treatment from you look like? What would a treatment from you look like? And what kind of things are you doing? What are you into at the moment that you found has given you really good results with patients? That you've kind of said, this is some way I want to kind of go further into this.
Yeah, so there was a couple of sort of integral moments, and one was meeting Cameron. He taught me a number of he treats quite he uses a lot of biodynamics, cranial, as well as MET, the sort of the classic structural approaches, as well as the indirect approach, and I found that I was getting as good, if not better, results with some of the indirect techniques I was using, that I was developing, that he was teaching me, as the sort of more direct or structural approach that I've been showed at uni. And so I had a keen interest to really explore that a little bit more. There were some things about sort of the way we were taught to challenge tissues. It didn't really sit right with me. I've had a lot of random injuries over the years, and I've had some very good treatment and some really quite ordinary treatment. And to see the results I could get by being really gentle, sort of intrigued. Number one, intrigued me, but number two, my patients actually really appreciated it. And so that's something I wanted to explore. One of the other moments was I actually took a dry needling course. It was at the start of 5th year, and I was feeling a little bit despondent with my skill set as it was. And I figured if I can do a dry needling course, it's another sort of arrow in the quiver and another draw card. Certainly in terms of getting a job, but also delivering treatment. And it was start of 2021. We're in one of those random COVID breaks that we were let out on good behaviour for a short period. And John Marshall was running a dry needling course in Melbourne. He was stuck in Singapore with travel restrictions, and so he got Saeed, the guy whose clinic I now work at, to demonstrate as he'd done acupuncture. And in one of the breaks, Saeed, we was talking to Saeed, and we were talking about dry needling, and he sort of expressed that as much as he'd learned about acupuncture and knew how to dry needle quite well, it wasn't something he used a lot with patients. And he was talking about fascial counterstrain, which I hadn't heard of at that stage. There was a 5th year student from VU who was talking about his hip, and Saeed just did a really quick demonstration where he took, this guy had basically been told he had FAI. Saeed did a couple of very basic motion tests on his hip, said, don't think it's that, let me have a look. 2 quick releases, and this guy's leg went from about sort of 30, 40 degrees abduction to sort of 60, 70. And it was night and day. The change was huge. And it was just like, okay, that's really cool. Is that replicable? Is that something, can anyone do that? Is this a party trick, or is this really a thing? And we all motion tested his hip afterwards. It was complete change in range of motion within the hip joint itself. So I was like, okay, this needs further exploring. approached Saeed at the end of that session as well and just said, would you be open for me to do some obs? I want to see what you do. Went along to, he was practicing up in Greenvale at the time, went and did obs with him for an afternoon. And again, just he had a number of different patients through that afternoon with different presentations, and it seemed like he had a bit of an answer for everything with this technique, and got really quite dramatic results. Whether it was a shoulder, a knee, and a low back, I think were the first three I saw. And again, I was just quite impressed and healthily skeptical. You know, it's one thing to inhibit pain in the short term; it's another to actually get change for people. I had long-term tweaked shoulder that was flared up at the time. I booked in to see him about 3 weeks later, I think it was. And my shoulder went from really quite stiff and painful, 2 releases, up overhead straight away. It wasn't even like it didn't hurt anymore. It was like the pain hadn't been there, and the restriction was just completely gone. And that I was hooked. I was like, okay, nothing else I've seen does that. I want to do that. So I started doing courses in FCS, fascial counter strain, and yeah, it's been a bit of the whole journey of osteopathy for me has been a steep incline, as I think it is for anyone starting out, and this is just an extension of that. So it's there's a lot to learn. It's very involved. It's a very elegant technique. It's quite simple in principle. You find the thing that's stuck and find a way to unstick it. But it's very, very gentle. There's a way to have a conversation with the body that lets you know that you're treating the right thing at the right time, and the results are really, really quick and quite profound for people. So it's exciting.
All right. Well, why don't you contrast that or compare it to the traditional counter strain that people may have learned, the Jones counter strain. It might be a branch off that, but are there any differences? Yeah, are there any differences there between the fascial counter strain versus traditional counter strain?
There are. So it's obviously Dr. Larry Jones was the founder of Counterstrain, and he developed about 200 different releases with tissues corresponding to tender points or releases relating to tender points. One of his proteges, I believe there's only 4 practitioners in the States who are actually qualified by Dr. Jones himself to teach counterstrain, and one of them is a physical therapist called Brian Tuckey. Brian is now one of my tutors and trainers, and he's developed the technique from about 200 releases to there's over 2,000 now. It's really, really extensive. It covers every system. There's about 13 courses all up. The new courses coming out actually treat up into the brain as well. There's courses for central sensitization, viscera, lymphatic venous, arterial, 3 for the musculoskeletal system. There's, what else we got? Nerves, 2 courses for nerves, which I'm going to do later this year. And then they're all 3-day courses, and then there are 5-day courses you can do for each of those as well. It's a sort of a next step. But the main difference, the big revolution, if you want to call it that, is that Brian actually determined that as much as that tender point presents in the body, there's also a reflected point in the head, and so you can use the head diagnostically when you find an area of tension and find an associated tender point. You can confirm with the head what that release actually needs to look like. So it's when I treat, it tends to be a lot more of assessment to determine exactly what I need to treat, and I might only release or do 4 or 5 different releases, but it means that I'm not spending time treating something that either doesn't need to be treated or is a compensation pattern. I can find the thing that's the problem and treat the thing, and that's the beauty of this technique. So it's if you think of counter strain as the shotgun, this is the sniper rifle. It's it's more detailed, more involved. Rather than taking sort of regions of the body into a release, you're gliding specific tissues. It's a lot more about layer palpation and being a lot more precise with your anatomy than you need to be with counter strain.
Well, it sounds like there's more points to kind of know, so that would take a bit more precision.
Yeah.
Yeah, right. Okay. And so, do you find yourself when you're kind of doing, going into new areas, new courses, and you learn about something, do you kind of do a little kind of free fall into that technique? Do you on your own, like you might do something to do with musculoskeletal, and you'll go, you know what, I've got this problem now, and I might just try this. Do you do that yourself as somebody who's done a course in one thing, and you try to kind of make it overlap into the next, or into another problem or another issue or another? Have you tried that?
I mean, very definitely. I think you could appreciate it's never one thing. When someone comes in with a shoulder, it's number one. It might not even be the shoulder. That's just where they're feeling the compensation. That's where they're feeling the strain. But you've got to go looking further afield to find it. It's very unlikely it's going to be one thing. So once you've got these other systems to add to it, it's like, okay, well, what else can present with that kind of compensation pattern, with that kind of strain pattern?
Yeah.
And you can go looking. And again, going back to the head, you can actually, once you know the region that's causing the most issue, you can check different systems in that region of the body. So you can really quickly determine, okay, is there a lymphatic component? Is there a neural component? Is there a musculoskeletal component? And so you can treat to that. So sometimes you might treat all the lymphatic and venous from the neck to the arm, because you've determined that's the key system. Or sometimes you might treat multiple system for the region. So it kind of depends on the patient, and it depends when you find the most mess that you need to do your most work. But the body sort of tells you where to go and what to do.
All right. So it sounds like you're kind of really, I guess, building your career around this. I want to call it just a technique. It sounds like it's a concept within osteopathy that's kind of helped you also apply your osteopathic thinking to it. My question around that is that do you find that now, are you still taking more time to kind of delve into that, or do you feel like once you've done that, you'll kind of move on to something else?
I'm going to be in this for a while. But I'm agnostic in the sense that if something better comes along, if someone shows me something that works better, faster, with less risk, all the rest of it, I'm not, I don't see a sunk cost with this. And that's the same sort of feeling I had for osteopathy in general. It's just like, I wasn't going to stick with osteo just because I decided to do it and I was that far down and there's no turning back. It was because I knew deep down that this is something I could do, should do, and wanted to do.
Yeah.
And that's why I stuck with it. And it's going to be the same with this technique. It's going to be a number of years before I've worked through the curriculum and really honed the skills. But if something turns up tomorrow that someone shows me another way, I'm
Right.
I'm not tied to it in that sense.
Okay. Look, it sounds like it's really given you a bit of passion for osteopathy, which is a great thing. Where can people find out more about it? Like if people want to look into fascial counterstrain, they want to learn the courses, where could people find out more about it?
So there's two centres in Australia which teach it. One here in Melbourne, which is run by Saeed. That's Fascial Counterstrain Australia, and then the Jones Institute in Adelaide runs courses as well.
Right.
So they run the Jones Counterstrain as well as the Fascial Counterstrain out
And
of Adelaide.
you've had experience with both of those courses, or?
I haven't been to Adelaide. I've met some of those guys. They've been over and trained. Some of the clinicians from the States come over and deliver courses, and when they've come over, the guys from Adelaide have come over and joined us in Melbourne. But I haven't trekked over there as yet.
Yeah, right. All right. Well, maybe we'll link to it in the show notes, so if people want to find out more about it, they can kind of go there. So, Jonathon, I want to ask you. Earlier, you mentioned that one of the things that really got you early on was, you'd be driving to work and you wouldn't know that, what kind of results you were going to get or what to do with a patient, or you really had no idea what you were going to do with the patients that you were going through in your head, and that gave you a lot of anxiety as a really in your early days of practice. Why do you think that is? Why do you think you felt that? Like what? I mean, now that you're doing a little bit better, and you said that you've moving on a little bit from that, have you had a chance to reflect and see what happened?
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode, and please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Yeah, it was twofold. One, we just come out of COVID, which had its own challenges, especially down here in Melbourne. The other was just a deep disappointment with the program that I just completed with the RMIT program. I really didn't feel they prepared me as an osteopath, and I've openly said this to the educators since. I got on fine with 98% of the educators, and still chat to a few of them semi regularly. The thing I said to them, and I'll say here, is that I graduated with an osteopathy degree. I didn't graduate as an osteopath.
So you were an osteopath by registration only. You don't feel like you're an actual osteopath?
No. Right. I wasn't thinking osteopathically. I wasn't approaching treatment or assessment osteopathically. I'd been given a long list of orthopedic tests that I could use to formulate a diagnosis, with the caveat that those diagnostic tests were highly flawed. Some of them are completely useless, and some of them are semi useful in some cases. So it was where to start. I could take a great case history because I can talk to people after years of snowboard instructing. I know how to relate to people after hanging out in the mines with a bunch of people who, generally speaking, are fantastic blokes, but I don't talk about NRL on the weekend. It's not my thing. But you still got to find a way to relate and chat to people if you're going to be in the dark for 12 hours with them. So I could talk to my patients, but I couldn't necessarily.
Yeah, but that's not something that you learned. Yeah, sorry, that's not something you learned at university, though. That's part of your personal skills that you would have brought with you anyway. All right, so look, I want to go diving into that a little bit and explore your experience, I guess. And my first question to you is, most of the people that I've talked to that are really passionate about osteopathy, they're hooked straight away because you would have received it one day. You mentioned it actually earlier when you saw Saeed perform the FCS techniques, and And you said to me, you're like, wow, that's it. I wanted to know about this. I was hooked. And that's how I felt when I went to my first year, first semester, first week, first hour of osteopathy class. I was hooked just because the person that presented that class, the two people that presented that class, had a lot of passion for what they did. They made sense. They made it make sense to a 18-year-old young boy like me. And you know, you looked at these people and you couldn't see but passion for what they were doing, and that speaks volumes, because to move a human being to that kind of passion, there must be something special into it. So at least it gives you the inquisitive mind to know, hey, I want to know more about this. And so, did you get that? I mean, did you get that in the first year, first week, first semester, first hour? Was that something that you got? What was your experience like in that first exposure to osteopathy in the first semester, I guess?
It was fleeting and sparse. There are some fantastic practitioners who still teach into the program, but generally speaking, they do a guest appearance. Some of the core staff, and certainly our first year coordinator at the time, sort of openly told us that they'd lost compassion for their patients, and that's why they had to step away from clinical. They didn't have a strong belief in the technique as being that effective, or the sort of the approaches that effective. And you could see that the times when people were actually paying attention was when that same educator was telling us stories about treating. They were telling us about the success stories, or they were telling us how they were engaging with patients, good and bad. And that was riveting. That was interesting. So okay, that's a glimpse into clinical life. But in terms of the delivery of passion, there absolutely were people who did it, but they weren't front and center.
Right. So let me get this right. The first exposure that you had was from somebody who wasn't actually practicing at that current period.
That's my understanding, that at that stage, that our first year coordinator wasn't practicing.
It was communicated to you that they weren't practicing because they had lost compassion for their patients and for what they were doing.
That sort of came out a bit later on, but it was fairly obvious in the way they spoke about things that there was a reason why they weren't practicing. Yeah.
All right. Before I go on and ask you more questions about this, let me find out what kind of student you were, Jonathon, because we could sit here and discuss the course, and you could have been somebody who just didn't pay attention or just didn't want to be there. Or tell us about what were your marks like? What was your GPA like? What was tell us about that. Were you somebody who made a great effort? Were you somebody who wanted to learn and be educated?
Yeah.
You toot your horn a little bit, mate, if you need to, or don't. I need to know I need to get to the bottom of it.
I'll need to a little bit. So to give you an indication, so I can see RMIT from my house. I bought a house within spitting distance of the university, because I knew if I did that, I couldn't not go. It was from day dot. This is what I was going to do. This is where I was going to be. I went to pretty much every single lecture. There was a couple where I couldn't, because of work and other bits and pieces. We had 198 people start the course in year one. I topped the year in year one. We graduated with 113 in year five. I topped the year in year five. I was one of only two students to get a GPA of 3.9 out of 4 for the whole program. So out of 40 courses, I got the equivalent of 3 distinctions, and the rest were high distinctions. So I was there to learn. I was there on a mission, and I can appreciate being older with more on the line to prove, to lose, whatever you want to say about it. I'd been to uni the first time round as a 19-year-old, and I was there for all the right/wrong reasons. I was there to have a good time and meet people, and it was an absolute ball, and I've got some great mates still from it. But my marks were borderline at best, and I didn't finish that degree because it wasn't for me. And I joke that the best thing about the snow, it's kind of like uni, but without the assignments. It's party time. It's you're living in a ski resort. That was as much out of my system as it needed to be. That this, I wasn't going to walk away from a 6-figure job half-ass it. I didn't want to be a 50% osteo. I needed to be good.
Okay. So if there was something to be learned, you were there to learn it. If there was something on offer, you were there to take it with open arms.
Yeah, and I actually organised some of the sort of extracurricular stuff for my classmates as well. There was, I saw palpation as a big hole in our education. So I organised a palpation session with one of the tutors, and they very kindly dedicated 3 hours in an afternoon. I think we had about 40 people from the course come through at different stages over the afternoon. And yeah, I was there for the full 3 hours.
Right.
So I was very much a case of trying to drag myself and the other people around me. And shout out to the other people around me as well. Like I made a very contrived effort to make sure that I wasn't the old guy sitting in the corner by himself. I knew I wasn't going to get through the course by myself. I needed good people around me, and some of my fellow students who I was quite close with throughout the course were really dedicated. They were all ages, mostly in sort of early 20s to mid 20s. But there were some great students there, some really passionate people who were there for all the right reasons, and I aligned myself with them, so they could drag me along and I could drag them along where I could. So
Okay.
yeah,
So all right. Well, that's good. I guess then, in your lecturers, your tutors, the people that taught you, if I was to speak to them and say, what do you guys think about Jonathon? What would they tell me?
I mean, I think half would have decent things to say about me. I still get, like I said, I still get along fine with most of them, and a couple of others would probably think I'm a bit of a pain in the ass because I was badgering them for changes or for improvement or things I felt would needed to be improved. So
okay, so tell us about those things, mate. What did you think? What did you think the course missed giving you? Like, what did you? I mean, we know that it comes across to me that you felt like you didn't receive osteopathy in terms of the foundations and the principles, right? Like they weren't shown to you. They should have been shown to you in first year, right? That's when you get exposed to that stuff. And they seems like it wasn't. So tell us about that. Tell us about your first year and what happened there.
So the first lecture was pretty much the one and only time that we actually delved into sort of the roots of osteopathy in terms of sort of a brief history of who Andrew Taylor Still was and the development of osteopathy in Australia. And then it was into sort of the health science component quite strong. And as much as I do have beef with the program itself, they deliver good education. What they deliver was good. It just wasn't what I signed up for.
Right.
The anatomy was great, the physiology was great, the pathophys was great, the pathology was great.
You wanted more than a health science degree.
Well, this is the thing. I signed up to be an osteopath. And as much as not understanding all that other stuff is very important, if you can't translate that to a clinical outcome, it's a bit useless as an osteopath. It's
the whole
great
thing
knowledge
cost you,
to
mate?
have, but
what the whole thing cost you?
45K, I think.
45K.
Something like that, maybe a bit more. Yeah.
Yeah. Right. Okay.
Well, and then lost earnings and everything else. So yeah, it's getting close to 700. But that's
You'll get it back. You'll get it back. Right. So okay, and in terms of actually teaching you how to actually apply things in the clinic, how to formulate proper diagnosis, how to formulate treatments, how to put together treatment plans, the things that people do in clinic that makes them successful. Was that ever discussed? Like, what was that like?
There seemed to be a bit of a disconnect between the teaching staff and the clinical staff, because there was quite often times when, as a clinical group, we'd be asked questions and explain that we weren't confident, or we didn't know, or it had been mentioned, but we couldn't deliver an answer suitable, to meet their expectation. We'd turn around and say, we haven't really been taught that. And they say, well, of course you have, you should have been taught at that time. It's like, well, you've got 10 people here telling you that we don't know, and you're telling us that we do know. So you can either be upset with us for not knowing, or we can just learn it and just fill that hole for us. So there seemed to be a bit of a disconnect. And it was, we did two two courses on the sort of, they were it was called medical exam 1 and 2. Med exam 1 was more sort of vital testing, and then med exam 2 was all the orthopedic testing. And that was, apart from a little bit of sort of joint isolation, passive ROM, active ROM, the sort of osteopathic diagnosis wasn't really taught in the academic sense. I don't feel anyway, and we got that in pieces from our clinicians when we could, bearing in mind that I was sitting in fourth year really worried about the fifth years, because that was 2020 when we were in lockdown. I was thinking, these guys, they've only had 1 year of clinic, not knowing I was going to be rolling into 2 years of COVID disrupted clinic. So
all this stuff was more implicit rather than explicit, right? Like you'd get to clinic and you'd be implicitly kind of talked about rather than explicitly educated on.
Yes, I think there was an expectation that it was going to be explicit, that it had been explicit, and we didn't feel it was. There was
let me give you a little bit of background so you can answer the next question for me, mate. When I was a young student, I guess I was a young student because I was 18 when I started osteopathy at UWS. We would hear about the amazing course down in Melbourne at RMIT. That is the first. The RMIT used to be the Phillip Institute, and the RMIT course, the osteopathy course, is actually the first course in the world of its kind, which means that it was the first course that was graduated, the first tertiary education official university course that actually, graduated osteopaths who could then be registered. And that's a big deal, right? And so we started the University of Western Sydney course. I think the course started in '98. I was in the class of '99 that started, and once we got to clinic, we would just hear of this amazing course in Melbourne that was just it was graduating superstars. We had some clinicians come down from that had only been out for a few years, like Liz Howard and Kate McPhee, I think her name was, but just amazing osteopaths who you could just tell that osteopathy just oozed out of them, right? And we had them and they'd only been out for a few years ahead of us, like they'd only been graduated for 4 or 5 years, and you could already see the quality in their osteopathic thinking and the way they thought about things and the way they put together things, and they were talking to us in the way that you said that would provide some passion. They'd tell you about their cases and what they did and what the outcomes were, and that really helped us. And they were from RMIT, and we'd go, geez, we felt inferior. We felt inferior to the RMIT graduates, and now hearing you talk makes me a little bit upset, because that was such a good course. And what you're telling me now is that almost is non-existent in terms of the quality of osteopathic education that's coming out of that institution. My question is, why do you think that is? What's happened? What do you think's happened down there? I mean, there was so much class coming out of that university. Why is it the way that you say it is?
I think it's somewhat threefold. I think it reflects the schism within the osteopathic profession at the moment between the all into evidence-based medicine and the people who still have faith that the concept of osteopathy works and can be relied upon in place of evidence-based medicine, or alongside evidence-based medicine, I should say. I think it's pressure from the university itself. One of the gaping holes I felt was just prac time, just actually getting your hands on people, and not just getting your hands on, like, I was a great practice partner because I've beaten the crap out of myself over the years. So I've got problems. I've got things you can call dysfunction. If you're working with an 18-year-old, they're generally pretty light. There's generally not enough going on for, especially when you're starting out. Someone like yourself, I'm sure, can find problems with anyone who's ever played high school sport. But at that stage for me, it wasn't, it wasn't
I get it.
these glaring obvious things.
Yeah.
And you just don't have your hands on people. And I think that predominantly comes from a budgeting aspect. I think that the way universities have been pushed to become a business and maximize every dollar at the cost of the quality of education. And I think the other reason is actually comes down from the bureaucrats of places like APRA, where unfortunately we do get lumped in at times with some slightly questionable practices where, I don't think chiros have done themselves a great favor cracking babies on video. Not going to pass judgment. I certainly wouldn't do it, but I think we've been somewhat lumped in with that, and I think that's apparent when it comes to if you look at our insurance rates. My partner's a physio. She pays half as much as I do in insurance.
Yeah.
And there's a reason why our insurance rates are as high as they are. And it's the perceived risk, and I don't know if we've done enough as a profession to mitigate that risk.
Well, Jonathon, a lot of the things that we take for granted now, in terms of imaging rights and Medicare rights and so forth, most of those things happened when we actually we got those off the tails of being when we used to be the Osteopaths and Chiropractors Registration Board, right? So we were a little bit stronger in numbers, but we kind of copped a bit of abuse off them. They were, on the board, there'd be something like, 10 chiros and one osteopath. And so, but in saying that, it gave us a little bit more, because we a lot of our imaging rights, for example, we've had them since we were the same board. And so, yeah, I get that, them cracking babies on video doesn't give us a lot of, and we get lumped in with them, but we got to take the good. You take the good with the bad, but that's ultimately back onto us. And we can't blame anyone other than ourselves. So we got to look inwards on that.
Yeah. On that point, if I may, I still think, ask someone in the public what an osteopath is.
Yeah, they don't know.
The easiest answer for most people is we're halfway between a chiro and a physio.
Yeah, well, that's the closest thing they would get to you, and it's inaccurate. Yeah. So that's our problem. That's our problem as a profession, and that's an issue for the association, I think, to take up. And I'll probably leave that for another episode. Mate, do you think that there are people in the Well, I mean, you can only speak to RMIT because you were there. Do you think there are people in that program who have enough clout that shouldn't be there? Or that aren't pushing osteopathy, I guess. Not that they shouldn't be there, but they're not really pushing osteopathy. They're more just wanting to get, they're either academics, or they're not really concerned about our identity.
Yes, I think there are individuals there. So there's one of the senior educators who would be quite happy to see us go down that homologous allied health manual therapist route, that where there's not really that much difference between chiro, physio, and osteo, and we basically do the same thing. I think that's
what makes you say that?
Because he said it.
What piece of evidence? Because he said it, right?
Because he said it. So yeah.
Right.
So I mean, I'm not. Yeah, I'm not. That's not inferred. That was openly expressed. That they think that's the way we're headed, and that they think that that's appropriate.
Well, you can think that that's the way you're headed. I think that's the way we're headed too, but I don't think that's appropriate. I think that's something we need to stand up against. All right. Well, as you were graduating, I know that a lot of the times what ends up happening is that when you get to your fifth year, I think there's a lot of organisation that happens between the profession and the students that are graduating, especially in Melbourne. I think it's a lot more coordinated in Melbourne because there's a lot of graduates and there's a lot of businesses out there. And, you might get maybe the association holding a day, or the universities might hold a meet and greet for osteopaths and the students that are about to graduate. were there any concerns that were concerns ever voiced? Have you spoken to osteopaths who maybe have been around for a while that have said to you, we're concerned about this, we don't like what's happening here, we're not bagging you out, but we don't think you're coming out with any quality that we could actually use in private practice? We have to do a lot of mentoring. We have to put in a huge amount of effort to get you guys. Is that something that's been communicated? Did you hear that? Are people in Victoria? I'm only picking on Victoria because that's where there's two universities and I guess a whole bunch of graduates coming out and a whole lot of people who are practicing down there. Are there people voicing their concern down there?
Well, I mean, I think it's always going to be the case that Sydney-siders are going to pick on Melbourneites. It's what we do. But I mean, maybe not quite in such strong terms that they can't use us, because again, I think there is a skill set that is taught at RMIT that is appropriate and is useful.
Right.
It just doesn't go far enough, and we've got that sort of medicalization of allied health done quite well. It's the osteopath that's missing. But certainly the principal at the first place I worked was quite concerned with the feedback and the quality that she was seeing. Cameron said to me in the debrief from when I wasn't successful, he said, "You're a very good fifth year student. You're not up to graduate level," and right. That was potentially part of the reason why he was so open for me joining, because he could see that I needed to be and wanted to be, and perhaps that goes to some way for him inviting me along. Again, very grateful that he did. But certainly, I've heard a lot of people say the osteopaths that I've spoken to that are less inclined to jump on the evidence-based medicine bandwagon with both feet have said that they're worried that we're losing our identity, and in part, in no small part, that's due to what's happening at the university level.
Right. And do you think that they're voicing their concerns to the university? Like, when they have these meet and greets, I don't know who the head of the RMIT program is now, but do you think they're kind of being pulled aside and say, hey, what's going on? Like, I'm not sure the association is actually saying anything. In your experience, when you're a student, did you hear about anyone kind of saying, to the university higher uppers that, this something needs to change?
I know it was coming through. So some of the people who were teaching in the sort of like guest lecturers or clinicians, they were passing on their concerns, and I know good. we had a really high turnover of staff at RMIT. There were there were a few core staff, but there was a lot of people who sort of came in and came out, and I know that's happened since as well. They've had quite substantial turnover at leadership level within the osteopathy program, restructuring within the university as well, which doesn't help. And I know in part that was part of that frustration is the fact that they don't think the course is going in the right direction. Okay. And one thing something I was involved with in my first year out was I was invited to join a small group to talk to APRA, who are going through the new accreditation program. So every X number of years, the program needs to be reaccredited to make sure it's keeping up with expectations of industry and development in health and all the rest of it. And so I sat in on one of those meetings, and
that's a mafia meeting, mate.
A little bit.
Yeah, that's what that is. That's the regulator saying to the university, you need to change, otherwise we're pulling your accreditation, and that's when the universities change. And that's when it happens, right? That's when that's the meeting with the head boss, where you get told this is what needs to happen, otherwise we pull your accreditation and off you go. And then the problems start from there. But anyway, continue.
No, I agree. One of the things, so I worked for one of the colleges in the university as well. I worked for the college that oversaw the school of, so the program sits within the school, and then the school sits within the college. And I worked at college level as a customer service agent So basically helping students with enrollment, other bits and pieces like that.
Hmm.
So I was sort of slightly privy to seeing both sides of what was going on. And one of because there's also a move to push the program from the double degree it is now to the 3 and 2 undergrad and
Undergrad and
master's
masters.
model. And when I saw the structure of that, it looked like it was an even a bigger lurch away
Mm.
from osteopathy.
Yeah, no doubt.
And one of the conversations that I've had is that in effect you'd be learning to put your hands on people when you go into clinic.
Yeah.
And I felt it was already too late when in what we were doing and
Mm.
too thin on the ground in what we did. And I see that as a massive step in the wrong direction. I mean,
Well,
for instance,
yeah.
I know at La Trobe, the physio program there no longer has a manual therapy component. There are no manual therapy skills taught at in the physio program at La Trobe. So everything seems to be shifting that way. And if we're trying to chase the coattails and respect that physio has, and we think that that's the way to do it, I think we're absolutely destroying
Well,
ourselves.
yeah. Look, everything is shifting that way,
Mm.
and I guess the regulator wants it like that. The regulator wants us to all be the same. I understand that. I mean, I don't like it, but I understand it. A university is not going to stand up against that because the university wants to have that uniformity because then it can accept health science degrees into an osteopathy master's program, and that just allows more money to be made. And so,
Yep.
I understand that. I don't like it. So we have the regulator and the university who against us, little old us. So what do you do? Well, you need to come up with a solution. You can't just sit on your hands and let them take the ball and run with it. You need to come up with a solution that doesn't that gives them what they want and gives us what we want. And I don't think that there are enough people butting their heads together. Well, first of all, I don't think there's enough people saying that there's something wrong,
Mm.
and I don't think there's enough people butting their heads together, thinking of a solution, and then trying to implement it. And so, yeah, we're on a downward spiral at the moment, and I'm not sure. I'm not sure if there's any way to stop it without some serious intervention. I guess from the profession. We're
Mm.
the ones that have been agents of change in our own profession over the years. When you study history, but it gets harder and harder as time goes on. But it's still achievable. But I think we just need some better leadership. Jonathan, given your experience at RMIT, if you could if you could change the things that would actually have an effect, what do you think needs to be changed there that would that could be changed? Like, there are things that can't, like, patient numbers at a university clinic would need time to pick up and so forth. So your exposure to patients. But in terms of actually classes and learning and understanding principles and understanding osteopathy, if you could change the things that could be changed, what is it that you would like to have changed in that program that would make your life easier as an early graduate?
Um, so the number one thing is just your basic skills. So I think we should have had a lot more prac time and a lot. I think we could start in clinic in first year delivering massage,
Right.
doing just really basic soft tissue skills that allow you to develop your palpation. It's an absolute fundamental skill if you're gonna become any good with your hands. You need to know what something feels like. Um, and I think that could. I know at VU you start doing OBS with senior students in third year. We don't. We sort of we were encouraged, and then it was sort of made mandatory that we would go and have an appointment with a student clinician, student practitioner once a semester, which is good. At least you get to see what the inside of the clinic looks like, and you sort of get to picture yourself there and what that would do. So you understand the process, but it gives them some patient numbers as well. but we could start with the basics a lot sooner, a lot more hands-on time. I know, again, to compare ourselves to the Chiro program, which has now been wrapped up at RMIT, interestingly enough, they were doing pretty much double the prac time and double the clinical time throughout the entire program. They had a lot more hands-on time, and they weren't even allowed to put a thrust through until fourth year. We learned HVLA in third year. They learned positioning and setup through their undergraduate years, and it wasn't until that fourth and fifth year they were even allowed to manipulate, put a thrust through. But they had double the hands-on time. They had double the prac time, and I think you can't be a manual therapist if you don't know how to use your hands. And you can't be an osteopath if you're not a manual therapist. So that's my spin on it. I think,
Right.
Yeah.
How important is having the right people there, like in terms of the first year, first exposure? Yeah, right.
Yeah,
So
it's huge.
I mean,
It's
that's something that you can change, right? That's something that you can, there's so many good osteopaths in Victoria. It's not funny. I spoke to Wael Mahmoud on a podcast. He was one of the first, I think, people to head up that program in 1987. And he said, "Oh, I'd love to go there and teach," and so that I think we need to make an effort to reach out to people rather than just put an application, in and have a job application on Seek or something like that. Like, come on, you've got some people there that are been practicing osteopathy since the 80s and 90s, and go and have a chat to them. So we'd love to come and have you teach here, come and teach our first years, give them a bit of passion, give them a bit of excitement for what they're about to go on to do. Because I'll tell you what, it gets harder in second and third and fourth year, but those first lessons always stay with you. And if you got those down right, you'll persevere through. But if you don't, you'll drop out. It'll consume you. And so having the right people in place, I think, is important. And in terms of actual seeing patients, what I wanted to ask you was, tell us about COVID. Like, we blame COVID for this? I've spoken to other people, and they're kind of blaming COVID. They say, well, students didn't really get as much hands-on experience because COVID just hurt the last 5 years of students. I think this problem has been happening for at least maybe 10 to 12 years ago, which predates COVID. But can you shed some light on that? Do you think COVID was a massive problem, or do you think it goes deeper?
Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
I think it massively accelerated the problem, because more and more it demonstrated that you didn't even have to run an in-house lecture. You could do everything remotely, or you could do everything pre-recorded. So for me, the big again, I had to sort of explain to some of my cohort that when I first went to uni in 97,
Yeah.
if you needed to look up a journal article, you went to the library, you got out the microfiche, you put it under the scanner, you looked around, you read the abstract, you decided if it was remotely reasonable and appropriate. You walked halfway across the library, pull out this giant tome, slam it down on the desk, flick through, read the thing, realize it's got nothing to do with what you need, put it back and go again. So your reference list was about 4 or 5 things long, and 2 of them would be the textbook, because that was sufficient, and it took you a day just to do that. Whereas now everything is at the touch of a button, and there's this idea that everything you're given in the course and in the lecture slide is all you need to know. and that's now delivered on a pre-recorded video that you can watch in 1.5 speed or not. And as long as you scrape through the end, then you're okay. There's the only time you need, we were still getting students that like, even in 5th year, we were walking when we had like an in-class test, you're walking in and you're looking across, it's like, how have I never seen that person before? If we're a cohort and we've been in this for 5 years, now sure, people chop and change and move around a little bit, but you're still seeing people for the first time when you actually had to go in. And I don't know how you can run a program like that purely digitally. I know in COVID we had to, but there was, when we did have those opportunities to get back face to face, they weren't capitalized on. And I think VU did a better job than RMIT, but I've spoken to some of those guys and they didn't do a great job either. And a lot of that, to be fair, they had some pretty limiting parameters to work within, but there was no recognition that actually this is a problem and we need to actively put something in place. It's like, well, this is the best we can do, and as long as we can tick that box at the end and you're safe, well, then we'll graduate you and you can figure it out there. But I think it put the screws on a problem that was existing. You know, I know there were students who were in 5th year when I was in 1st year who started when Ray was still running the program, and they saw some of the major changes that happened when he stepped away.
Right. Do you think that's a turning point for the program?
My interpretation is that it is. I wasn't there under Ray. He came and did a guest lecture, which was fantastic. But the impression I got from the 5th years who were leaving was that things had become very different under the new structure, and I think that was really the hard turn. That's my impression.
Right.
Yes.
Right. And so, are you still in contact with a lot or any of your former classmates, cohort? Have you maintained friendships? Have you maintained contact with many of them?
Yes, a small number. One guy I dragged into the FCS rabbit hole with myself.
Right.
So he's coming over tomorrow. We do sort of weekly or semi-weekly shoots just to
Good.
keep practicing, keep learning.
Okay.
And there's a couple of younger students coming through, but yeah, a few of my cohort I still touch base with.
Good.
Regularly.
And what are they telling you? You know, what's their experience been like? You know, is this across the board or is it just Jonathon? Are they,
Well, I mean,
are they
a
struggling?
couple have left the industry already.
Right.
Or they're doing associated type things, more sort of like one of my good mates from the program is working in medical implants. Got a great career and really enjoying it, thriving in it. And osteopathy gave them that, so they're not. They had a bit of a meet your maker moment when it was when they made that decision to step away from practicing, but I think it's done them well. For some of the others, I think some have sort of gone down the exercise route, which I can understand. They work with sports teams and they work in those sorts of clinics where that's expected. And then some others of especially some of the guys who went up to Sydney, for instance, they're like, okay, so this is osteo. I know a few of them have either worked with Anne or sort of in that circle, and have been shown different things, and yeah,
they're happy.
they see the stark difference. Seem to be, yeah.
You don't leave a profession that you're happy with. And you don't leave a profession that you're getting results with and you're getting paid good dollar for, right? And so, whether they're interested in working in sports or whatever it is, osteopathy still applies. And I guess once you have that behind you, it doesn't matter where you go or what you do, you'll always get results and you'll always feel fulfilled. And so there's no reason to leave if that happens. If anything, you grow, right? You may not leave. You might just grow. One of the guys that I graduated with, I think ended up working with Nike over in the States, NFL, and Paul Francis went on to do some great things, and now I think he's heading up a a football team in Europe, like one of the soccer teams in, I think, the Polish league or something like. I got to get him on the podcast and get him on there. But he started osteopathy with us and just grew and grew into this kind of juggernaut in sports. Like with Nike and big companies like that. So it can take you to special places. But if you don't have the passion for it from the start, it's really hard to get. I always say the first 2 years of practice are the make or break. And if you don't get it right from there, it's really difficult to kind of hang into the profession. And I guess the same with being a student. If you don't get that first semester, really, like, you don't have to do well. I did poorly in my first year, and I did poorly because I struggled. Like, it's not lack of effort. I just struggled understanding concepts and understanding, even anatomy and physiology. But geez, I was hooked. Like I was still hooked, and that drives you on to kind of get past the hurdles. And if you don't get hooked, so one of the big things is you got to get first year right. And whoever was teaching you first year, they haven't. I don't think they've done the best by you, or from what it sounds like, you don't feel like that they offered you that passion, and and so that's a shame. That's a real shame. Jonathon, what are you excited about for the future for yourself?
Just seeing how far I can take this thing, to be honest. Like it does blow me away a little bit that I'm managing to get the results that I am getting now. Having quite starkly changed the way I treat and the way I approach things. The confidence I'm getting from doing. You don't get confidence from a textbook. You got to do the thing. And now I'm starting to get more patients, better results. Weird results as well. I had a patient. She'd had two months of chronic diarrhea, had been put on all sorts of medications, all sorts of other bits and pieces. Came to see me for some low back pain. When I saw her the following week, she just about mauled me for a hug because I got rid of it. Next day things went back to normal, and it was like, I certainly didn't go in with the intention of treating her diarrhea. I looked to see what was going on that was causing the back pain, and turned out that it was low visceral stuff. And who would have thought?
It's amazing.
Remove restriction from the small intestine and the bowel, and all of a sudden it works better. Who would have thought?
That's just basic foundations, right?
And it's stuff that again, this is the magic of what we can do. And occasionally, a patient will say, "Oh, you're a magician." It's like, no, I'm a technician. What I'm doing is I'm finding the thing and I'm tweaking the thing. The body's
and
doing
so
all
why
the
would you put that in the bin? I don't want to say for evidence-based practice. I'm saying, why would you bin that? Why wouldn't you want to hold on to that and grow it and pass it on to the next generation? Because the evidence is going to be the evidence. It's going to evidence will just keep growing. It'll just keep getting there. And if it's good evidence, it'll help us out. If it's poor evidence, it won't do a thing. Like, I don't know why there's got to be this kind of loggerheads of kind of evidence-based practice versus what we're trying to do. I don't think the two are antithetical to each other. I've said that a few times now.
No, but I think for a long time we've been looking at it for a seat at the table from people who don't want us at the table. And we're being forced to follow an evidence model that works very well for pharmaceuticals. It does not work for osteopathy or manual therapy in general. It's a protocolization which goes away from the concept of osteopathy, which is patient-centered care. So you can't have evidence-based medicine, which is an average of averages, that's been doctored straight up anyway. We all know people tweak their data because, those guys are a bit old and those guys are a bit young, and they're outliers, so let's get rid of them because they skew the data too much. What does that bell curve look like? And let's aim for the middle. Well, I don't want to aim for the middle. That's
average practice.
It's average practice and average results for the average person. I don't want that for my patients, and I don't want that for me when I need to go and get treatment either. And
that's not going to make you enthusiastic as a practitioner, right?
No.
No.
And I think people are a bit lazy with evidence as well. People want a piece of paper to say, if you do this thing, you'll get this result. And if you can't find a piece of paper that says that, then you'll say, well, this technique hasn't been shown to work, so therefore I'm going to err on the side that it doesn't work because I can't do it very well.
Yeah.
And,
Or
especially
they'll
as a
blame the
newer
patient.
student,
Yeah, they'll blame
or
the
they'll blame the
patient.
patient. And I think it's a self-fulfilling prophecy. If you decided something isn't going to work, it doesn't matter how well you do it. You're not going to perform that technique, that procedure, whatever it happens to be, in the way that's needed. And I think the other thing that ends up happening is that the kind of studies that work for manual therapy are lower tier. So instantly people look at them and say, well, it's lower quality evidence anyway. It's further down the hierarchy of quality. Therefore, I can't really trust it. But then, so if it says it does the thing, then people say, well, I don't know if I can really trust it because it's lower tier. But if it says it doesn't do the thing, people are like, oh, well, it doesn't work then.
Yeah.
So it's all this negative bias for the evidence that we're trying to use, and
It's all for a seat at the table that you said it right, that I want us there anyway. But one of the things that we need to have is a point of difference. And so if we're all just kind of following the same protocols, there's no point of difference. So that's not good for anyone. It's certainly not good for the profession. I guess then I want to just ask you a final question around, you and the cohort of people that you finished with. What is it that you feel has been the biggest thing that has not crossed over into your private practice? So let me get this question right. So has there been something that's been majorly missing in your education that you felt like you went to private practice and you go, I don't know this. Oh my God, why can't I do this? Everyone else can do it. I can't do it, and I should have been shown this at university. Has there been something that's really stuck out to you?
It's stepping from that sort of medical orthopedic diagnosis to an osteopathic diagnosis to a treatment plan.
Okay.
Like, where do I start? I have all these findings. Great. What does it mean? What does the body want? How am I going to unwind that thing that's been giving this person pain for however many years? When they've tried all sorts of other people. Just again, a little side anecdote, if I may. My colleague who's coming over tomorrow, we speak to each other regularly about our wins and our losses because I think it's really good to hear when people are struggling as well as when people are getting it right. He had a patient who fell over when they were 16, had strong coccyx pain that stopped them lying on their back for 22 years. They're now 38. He treated them using some of the techniques that we've learned. They could lie on their back for the first time in 22 years.
Wow.
And that's one of the reasons I like FCS as much as I do, because it joins those dots. It joins the dots from. It gives me a way to talk to the body and understand what's going on, and then it gives me an answer in terms of treatment. And FCS absolutely isn't the only thing that does that. I think it does it quite well. But we didn't have that. We saw some great examples of treating when our clinicians would show us, but they weren't always the best at saying, this is how I got there. This is how to think. This is how to, because ultimately osteopathy is not a set of techniques. It's a set of principles, and it's a way to think. And that wasn't conveyed in a usable fashion. That's something that I've had to find afterwards.
And that's what you paid for.
But that's what I paid for, yeah.
Yeah, right. All right, Jonathon, mate, I want to thank you for joining me tonight. Before I let you go, though, what I want to do is give everybody who is listening and maybe feels that they have a different story to tell to Jonathon's an opportunity to come on the podcast and tell me your thoughts about the topics that were discussed tonight. So Jonathan's version of events is his version of events, and from what he tells me, a lot of the people that he talks to share those sentiments, and if that's true, and I have no reason to believe that it's not true, then that's sad. But if somebody wants to come on the podcast and speak of another version, I'm happy to have them on. This is not. I always said this is a free speech podcast that you can come on and you can say what you like and we can discuss it. And so I just wanted to say that before I said good night to you, mate. But yeah, we'll say good night. Thank you for joining us. Jonathon, if people want to find you, mate, what's the best way to reach you?
So yeah, you can find me at the clinic in Gladstone Park at Complete Health Osteopathy. You shoot me an email. It's jonathanpbooth at gmail.com. You find me kicking around Mill Park here and there. But I'd like to say to you, Sammy, we all stand on the shoulders of giants. No one's got where they've got by themselves, and I want to reach out to people like yourself who are trying to make a bit of a difference and fill that void for people like myself who are coming out new and a bit lost in it all. People like Cameron who've helped me, Said who's helped me, and people like yourself who are making an effort. I think osteopathy is worth salvaging, and it's going to be the leaders in the community and the profession who do it. As much as I, like a rant.
It's a pleasure, mate. It's just a pleasure. Like it was given to me, and you want to wrap it up and give it to somebody else as it was given, right? And so it's a pleasure. I take as much delight in passing on knowledge as what I do in receiving knowledge. So, but thank you, and again, thanks for joining us. And I hope we can do a round two.
Yeah.
What I am thinking of doing is maybe speaking to. I want to try and get a recent graduate from all three universities that are currently offering osteopathy, and maybe do a little round table with all three of you, and have you compare and contrast your experiences. I think that'll be an interesting episode. But we'll get there. We'll get there soon enough. Jonathon, thank you for your time. Stay on the line with me. But for everybody else, thanks for watching.